Holy cow, what a great group of, what a great audience, being so punctual. I was going to say pertinent, but that wasn't the right word. For being so punctual. We're going to start in 30 seconds, I promise, just to get a few more people in. I do want to say that this is, we're so excited. We've had more registrations for this webinar than we've ever had before. So kudos to the audience. All right. Well, welcome. We're just going to do a few introductions while the rest of the folks roll in. My name is Amy Lukes, and I am the director of the AOT implementation department here at Treatment Advocacy Center. Just a quick thing about me. I'm a social worker by training. Most of my experience was working with this population in community mental health. So that's who I am, and I'm very lucky to work with this very talented team. Betsy.
Good afternoon, everybody. I'm Betsy Johnson, been with Treatment Advocacy Center for about 7 years. Love working with Amy and Brooke. It's a real honor, and I'm really excited about today's presentation. So thanks so much for joining us.
And then Brooke.
All right. Hi, everyone. My name is Brooke Gentry. I am the AOT Implementation Coordinator at Treatment Advocacy Center. And I've been here for a little less than a year on the implementation team with Amy and Betsy. And so I am going to kick us off. Thank you, everyone, for joining us. We are so incredibly honored to host longtime AOT advocates Jerri Clark and Leslie Carpenter this month for a presentation on their open letter, What Families Want Out of AOT. I had the privilege of attending the family focus group and later panel at Treatment Advocacy Center's National Symposium in San Antonio last year, where this took place. And I want to emphasize how incredible those sessions were and how thrilled we are to continue that impact here today. And just the care and compassion with which Jerri and Leslie facilitated the family focus group was incredibly enduring. Jerri Clark is a family resource and advocacy manager at Treatment Advocacy Center. She lost her son, Calvin, to his severe mental illness in 2019. She lives and works in Washington State, where she actually started a grassroots organization called MOMI, Mothers of the Mentally Ill, to advocate for mental health care reform in the Pacific Northwest. And Leslie Carpenter is co-founder of Iowa Mental Health Advocacy, which is a lobbyist in the Iowa legislature. And she is an advocate on behalf of people with serious brain illness. Leslie is behind successful efforts to create an AOT program in Iowa's 6th judicial district. And Leslie and her husband, Scott, have 2 adult children, one of whom lives with schizoaffective disorder. So basically, the way that this webinar is going to work is you will not have your camera or microphone on during the course of the presentation. However, you will be given space to ask questions and join the discussion following the presentation, at which point I will briefly cover best practices for that. So if you can save your questions for the end, you can still submit them through the chat and Q&A functions as we're going along, but they will not be addressed until after the presentation. And then also a copy of the slides and a recording of the presentation will be shared with you after this. And finally, for anyone who wants to view the closed captions for this session, you just need to click the Show CC button, which should be on the bottom right of your screen on that bottom toolbar. So I'm going to go ahead and hand it off to Jerri and Leslie for now. Thank you both, and thanks everybody for being here.
Thank you all for coming. I'm going to be sharing my screen to run the slides, so bear with me while I open the slide presentation. And I will put it in presenter mode. And anybody on the panel, let me know if there's anything going wrong, but I think we're up and running. So the title of the family focus panel was, what do families want out of assisted outpatient treatment?
And the idea for soliciting input from family members actually was brought forward from Judge Eleanor Stormer and Dr. Dan Garza. And it really helps to understand that they were wanting us to have a voice at the AOT symposium that was held last year in San Antonio. And it meant a lot to me that they wanted that information, because Dr. Dan Garza has run the AOT program in Queens County as a medical director since 1999 in New York City. And Judge Eleanor Stormer has been running the New Day Court in Akron, Ohio since 2016. So they've already been doing this work for a lot of years of working with our loved ones, but they really wanted to promote the ability of families being able to share information with them that we wanted them to know. And that was really meaningful.
While we were having our conversation with about 30 family members at this family focus group in San Antonio, we had an artist named Erica Boda from Canada who was online and observing the family focus group. So while we were talking, she was building a graphic representation of our conversation in real time. So throughout the presentation today, we're going to share snippets of that graphic rendering, but for now, ta-da, I want to show you the entire graphic rendering, which was available at the conference by that afternoon and was shared with Judge Stormer and Dr. Garza, for example, before we presented on stage about what had been discussed at the meeting. So at the family focus group. So it was very cool to have this visual presentation available for sharing around the symposium right after families had opened their hearts and shared this really important information.
So to guide the discussion beforehand, we had developed a few questions to kind of solicit input on a variety of aspects of what it's like to be a family member. And they varied from things like, what do families offer? Why should you be soliciting input from us? Things like, what do families need? And especially, what haven't we received before our family came to you? How could you be including us to be one member of our loved one's treatment team? Our ideas for improvements, what's our role? And this question was really interesting because it is, the discussion ended up being about what has our role been, which often is much more extensive than most of us wish it had been, just to keep our loved ones alive, right? But it also was, what do we wish it could be? And what do we hope it will be as our person is helped by AOT? And then also some simple things about how do we care for ourselves?
So the emergent theme from this entire conversation, and the conversation continued beyond the family focus group as people were getting to know each other at the symposium, and then through other communication pathways that were opened through this process and continue to this day. But throughout all of this dialogue, the emergent theme is that families want what any family would want if one of their loved ones had a serious, disabling, and chronic medical condition. We want professional services. We want respect for our loved ones and ourselves. We want the care that is provided to be holistic and whole life person-centered care. And we want our loved ones to be enabled and empowered to survive and thrive despite the disability of these severe and persistent psychiatric conditions. There is a hashtag families like ours that is commonly used by hashtag families like ours. And I love that it made it into the graphic representation shown here. I want to say one more thing about this emergent theme. I had a conversation yesterday with a family member who was told recently by a provider that because their loved one with psychotic delusions that have made this person believe things that are not true about their family, the provider said to this family caregiver, "Why do you care? Your daughter doesn't want to have anything to do with you anymore."
Excuse
Bless you.
excuse me.
Why do you care? Your daughter doesn't want to have anything to do with you anymore. And I wanted to bring it up because that was an emergent theme in our family focus group, being told by providers to just drop it, to just let our loved ones disappear because they don't want to communicate with us. Their lack of desire to communicate with us is their disease talking, and often rooted in paranoia and delusions related to their illness, not because we do not have a loving relationship with them. So that was a really important theme that was brought to my attention again just yesterday in conversation with a parent. The answers that came to us in this focus group, and this is a really nice picture of our diverse and wonderful group of family members, they were willing to talk about things that were raw, that were emotional. There were a lot of tears. And there was also this element of emerging hope that these kinds of conversations could support professionals in doing their jobs well so that we can back up and be family members again. We want to be cheerleaders for our loved ones, but we don't want to be their therapists. We don't want to be their nurse. We don't want to be their care manager. We want hope that once they have made it to AOT, all of those professional roles are covered and we get to be a mom or a sister or another loved one and be an expert in being a loved one. I love that that made it to the t-shirt of this character from our graphic rendering. I want to be an expert in being a loved one. I don't want to have to learn all of those professional jobs that are not my area of expertise.
Well said. And families also shared about, sometimes it can seem to providers and others in our community that we are making really cold choices by no longer allowing our loved one to live within our home. And what that is really setting up a boundary of safety. When our loved ones are not well and they're not treated, they sometimes are dangerous to us, to themselves, to our other children that we have within our home. And some of us have to come to the decision to no longer let them live with us. But if we come to that decision, sometimes that's the only way we are able to convince the doctors and social workers to get our loved one a higher level of care, to get them into a treatment facility or a group home, someplace where they're able to stay healthy. But we are still there. We are still loving them. We are still supporting them. We're still in the fight to get them well. And it is a horrible, heart-wrenching decision to have to make that decision all about your own child, to have to not let them live with you anymore. But we want you to know that we have reasons for that, and they're well-founded reasons. These tragedies do occur, and we all know that if we just read the paper every day, right? So we just want you to know that we are not closing off our love for them. Sometimes we just have to do these difficult choices. And the other thing is, along the way, over the course of our loved ones' illnesses, we receive a whole lot of blaming for causing our loved one's illness, or blaming for not having our loved one get better or be responsive to treatment. And we get criticized from every angle. I've been told that we were too strict. I've also been told that we were too lenient. I've been told that I was too caring or too cold and aloof, right? If you can imagine an angle to be criticized from, believe me, I heard it all. And it's really hurtful when you know in your own mind and in your own heart that you were doing the best that you could, and that you parented that child just like you did your other children, right? And we can be at peace within ourselves, but it still has an effect on us. It hurts when all that type of judgment accumulates over the course of years. And so we really hope you will understand with us that these illnesses are biological, they're genetic, they're not our loved one's fault, they're not our fault, they just happen, right? And it helps if you can approach every family with that attitude of understanding that we did not cause our loved ones to be sick.
You got so many floating hearts on that one, Leslie, beautifully stated, and so, so important. We want to be collaborators with the care team. We want to be partners in care. We are really good often at taking notes and sharing those notes. So we do want our input to be valued. We also don't want to be responsible as the only ones keeping track of medical history and the clinical information that we want the professionals to track and use in care planning.
And we want you to know that we really are pretty good historians of our loved ones' illnesses. Most of us that have been doing this for a while, we all have a one-page sheet that has a simple thing from our loved one's diagnosis to their current medications, to any medications that they can't take, right? Maybe their hospitalizations. We can give you that very succinctly. But we're also the eyes and the ears for you for the other hours that our loved one is more with us than they are with you, to let you know if you're doing a medication adjustment, we can let you know if our loved one isn't sleeping for 2 or 3 days, or if they're having some other side effect. We can be your eyes and your ears, giving you input that helps you to have a more well-rounded understanding of how our loved one is doing. And we hope you will value our input when we provide it.
We really want to know if things are starting to go south. We want to partner in preventing crises. And another really strong emergent theme at the family focus group and beyond is the number of families who have been told your loved one isn't sick enough yet. They're not at rock bottom. They're not in crisis. Being psychotic is not illegal. So until those criteria are met, something illegal, a full-blown crisis, rock bottom, that's when the system decides to kick in and maybe do something. And our families do not want that status quo to continue. And we presume that if our loved one has finally made it to the magic place of assisted outpatient treatment, that will stop being true. That it no longer means that our loved one has to go into a full-blown crisis, hit rock bottom before somebody's going to intervene and shift from a downward spiral to an upward spiral. So let us partner with you in preventing crises instead of forcing crises. And thank you, everyone, for those wonderful emojis in response to that important piece of our message. We also heard from a diverse group of family members about how important culturally appropriate resources and care can be, and honoring the differences of individuals within a culture that are going to need an approach that is appropriate to them and to their family. All people deserve respect and have a right to individualized services. And although I don't think anyone in this room today is going to argue that individualized services are not necessary, we all know that. We know individualized services are necessary, but that's not the status quo that most of our families have witnessed. So that's got to shift. We heard from one family that they pivoted from local resources to an online counseling service from another country in order to get anything that resembled what would be culturally appropriate. That is absurd in the United States of America in 2023, that in order to get culturally appropriate care, somebody had to pivot to an online service in another country.
So now we're going to go ahead and talk a little bit about trauma. And one of the things that we'd like you to know is that when family members of somebody who lives with a very serious mental illness hear the words trauma or trauma-informed care, we tend to be triggered by that. And there's a couple of reasons for that. One is when lay people hear the words trauma-informed care, they tend to make this assumption that mental illnesses, all of them, are caused by trauma. And the problem is that these serious mental illnesses, like I said earlier, are not all caused by trauma, right? Some are, but not most. They're pretty genetic, they're pretty biological. And yet, we also know that the onset and the experience of having a mental illness is traumatic. And Jerri, if you would go to the next slide. This is a self-portrait that my son drew early on in the course of his illness. And I don't think anybody could look at this and think that his illness wasn't traumatizing him. He literally drew a picture of his head exploding. That is traumatizing. It was traumatizing for me to even just see this picture, right? And the other part of things is that our loved ones experience trauma in the course of going to receive medical treatment for it, right? They get physically restrained, chemically restrained. They get blamed for their illnesses. They get blamed if they're not getting better. It is traumatizing both to have the illness, to seek medical care for it, for them, and it's traumatizing for us to witness that happening to our loved ones, right? And it affects the whole family. There was a quote on the prior slide that said, "Mental illness doesn't run in my family." It strolled in, took its time with all of us. It affects the whole family. It brings dysfunction to our families. For most of us, the dysfunction didn't bring the mental illness. It was the other way around. And we also experience trauma ourselves as loved ones of somebody who has a serious mental illness when they can't get the treatment they need and they're untreated. Sometimes they are very verbally abusive of us. Sometimes they're physically abusive of us. And while we know cognitively that it's the illness causing these behaviors towards us, it still is really traumatic to experience that day after day after day and year after year after year. And so we ourselves are often getting PTSD and not even realizing it. So, when I'll give you an example. One time when my son was being prematurely discharged and I knew he was threatening my life, when they told me he was being discharged, I literally threw up. It's not normal for somebody to throw up when they hear a loved one's going to come home from the hospital. But it's that much. You are living in fear 24/7. You are on guard. Your hackles are raised all the time. And we might seem overreactive and overprotective and oversensitive, but we have lots of good reasons for that with our experiences. And when you're first meeting our loved ones and us, right, as a patient is entering your AOT program, we've been through a lot. And we might all be in different phases of healing, different phases of knowledge, different phases of being able to even talk without crying. And we hope you're going to meet us with grace and grant us some grace and understand that we are all doing the best we can with where we're at so far.
Our families want to stay intact. And I don't think this is commonly understood because a lot of providers talk about families as part of the problem. The family's already broken, so what difference does it make if we engage with the family? Maybe we have had to take out an order of protection. I had to take out an order of protection against my son for a variety of reasons, one of which was to make him eligible for some of the services that he needed, but also because I wanted to protect myself. I wanted to protect myself because I didn't want him to hurt me. But one of the reasons I didn't want him to hurt me is that I knew he could not live with that. If he hurt me in the throes of psychosis, that was going to cause further trauma and make his disease even more intractable. So it's complicated, But we do want to stay intact, and we need the support, the communication, the education, and the resources to help us stay intact instead of being blamed for some of what has gotten broken in our families because of these illnesses. Sometimes we have to leave jobs or take inordinate amounts of time off in order to manage what's going on. One of my son's incarcerations, I spent an entire week unable to do anything except try to manage what was going on with him while he was in psychosis, in solitary confinement, in a suicide vest. And trying to figure out how to help became my full-time job that week.
And sometimes when it can seem like a family and a loved one with a serious mental illness have become estranged, excuse me, and it seems like we might have abandoned our loved one, it isn't the case. Sometimes they have walked away from us. Many times they're developing a lot of paranoia. That's a pretty common thing that happens, is people develop a lot of paranoia about their loved ones or whomever they're living with at the time. And they walk away from us when we're simply trying to help keep them alive, literally trying to keep them alive. And it is really hurtful to be on the receiving end of that type of a delusion where they might think we're evil or Satan or any of those things that they often think. And we want you to know that even though that's happening, we're still there. We're still there advocating for them. We're still there supporting them. We're still doing whatever we know how to do to try to help get them the care that they need. We aren't going to leave them, even if they leave us. And all across the country, there are many, many people living on the streets and missing. They might be in jail. They might be in some other hospital. And the families are out there trying to find them, but they can't because there's even HIPAA barriers that prevent them from even knowing if somebody's in a jail or in a hospital. And so that's one of many, many barriers that we face.
We do the best we can with what we know when we know it. And I think this is true for me and many, many other families. We feel like we're always behind the curve in terms of learning. We learn the hardest way possible, the thing that we needed to know before we knew it. And so any information that is shared with us about how the system works, your role, our role, how we can collaborate, none of that violates HIPAA. But we are often told that we can't have communication because of HIPAA. That is untrue. And we know that now. But I think Leslie and I would both agree that we did not understand that we were being denied engagement opportunities because HIPAA was inappropriately applied. So we do the best we can. It's exhausting. Please remember that when you're treating our loved ones, that we are their family for life.
And we want you to know that we truly appreciate the work that you all do every day to help our loved ones, right? Many times we don't even get the opportunity to tell you that. There's not an opportunity to talk to you privately. My son, I know, would react negatively if I said something positively to his doctors and nurses. So I had to be very careful not to do that in person. But for all of you joining us today, we really appreciate all that you are doing. And we want you to know that we know that you might be the first ones who actually stay in the game and commit to treating our loved ones no matter what, right? You aren't going to walk away from them. And we are so grateful for that, because by the time our loved ones have gotten to you, believe you me, they've been fired by many a doctor, many a therapist, many a hospital. Even though that shouldn't be legal, it is. And we really appreciate that you are doing this high level, collaborative, intensive, hard work, right? We thank you.
Because any moment that we ever get with our loved ones who are the sick, that is a moment of reunification and shared love, is precious. And having lost my son to his illness, those moments are invaluable. So we also want you to know that the work we're doing for our loved ones isn't all that we're doing. Many of us are working really, really hard to change the system that you're trying to work within. This meeting that I had with Governor Jay Inslee in the state of Washington happened while my son was incarcerated in Seattle in a severe stage of psychosis. And I got a meeting with the governor to say, we got to change the system. Where do we begin? Leslie's got her own story. She knows a lot of politicians.
So I live in Iowa. And so during the prior presidential caucus this season, we were able to meet with all of the candidates that were running for president. And we provided them with very good, outstanding federal policy changes, state policy changes. Several of the candidates came out with really good mental health plans. And, you know, President Biden was pretty wonderful. And I don't know if all of you are familiar with all the things that they've put into their mental health plan, but they have provided additional funding for AOT. They provided funding for increasing reimbursement rates. They've provided increased block grant funding. It hasn't been everything that we all asked for, but we have gotten some of that. But here's my ask of all of you. We can't do this alone. And some of you are already engaged in advocating to improve the system, and we thank you for that. If you're not yet, please think about joining us in this work, because if we want to get somewhere, we need to create a social movement. We have got to increase the number of voices doing this. And we really could use your input. We know a lot of the solutions, but we bet that many of you have more solutions to provide. And we encourage you to email Jerri and me, email TAC, by all means, because the more input we get and the more hands and feet on the ground, the better we're going to be and the more change we can see coming.